Good evening, everyone. Welcome to another session of expert class as a part of academic excellence from the Department of Critical Care from Yashoda Hospitals. So this week we come across with another new topic that is the most pondering question because ECMO has been widely practiced nowadays. The question would be you probably see multiple cases of cardiogenic shock. But the most elusive question is, should we consider VA ECMO and switch it to VAV if it is required at later part of the disease progression, or should we straight away go ahead and straight away consider a hybrid ECMO mode, that is VAV ECMO. So, to begin this discussion, we have Dr. Nishant, who is a consultant from the Department of Critical Care, Yashoda Hospitals, High Tech City, who will be presenting this. And to moderate this session, we have probably one of the best experts from the globe, that is Dr. Bindu Akkanti ma'am, who is head of the department and professor of medicine from Houston, who is practicing heart failure, and she is well known across for her expertise in the MCS devices. And we have Dr. Pramod K. Guru sir, who is also an internist, nephrologist, and an ECMO consultant from Mayo Clinic, Florida, who brings across his expertise on these MCS devices. So probably we have the best in the world to probably guide us and probably help us in making this discussion probably to next stage. Over to you, Dr. Nishant, for your presentation.
Good evening. Hope I'm audible. Please let me know if I'm not. Thank you, Bindu ma'am and Pramod sir, for joining. I'll just share the screen. So, I know you all are very tired. I know you had a hectic day, and I also know I'm the only one standing between you and your dinner. We'll try to make this as interesting as possible while staying hungry. So today we're going to look at cases where we come across cardiogenic shock and then decide about whether managing medically or going ahead for mechanical circulatory devices. So let me start by saying all cardiogenic shocks are not the same, obviously, or else I would not be speaking to you, right? Let's see why. Before that, let me introduce you to a couple of patients we got to manage this week. So, patient A is a young female who presents with acute gastroenteritis and develops hypoxia and hypotension during fluid resuscitation. On examination, she had cold peripheries, feeble pulse, and narrow pulse pressure on dual vasopressors and inotropes, and saturating at 84% on 100% oxygen supply. And metabolically, her ABG showed a lactate of 8. This is second patient who is a postpartum 9 weeks female with hypothyroidism, presents with lethargy and shortness of breath. On examination, she had a high workup breathing with again feeble pulse and developed narrow pulse pressure shock on dobutamine and noradrenaline. The saturation for 80% and 100% of oxygen on NIV, and her lactate was 11. If we go ahead and do the POCUS, this is how it looked. So this is the echo video, and the LVOT VTI calculated cardiac output was 0.53 in the patient A, and it was 1.37 in the second patient. Almost look similar. Trust me, I've double checked the admission numbers. There are two different patients presented to us in the same week. Before going ahead, we don't know the diagnosis yet, but let's try to answer these three questions, which actually help us bedside, not only for these patients, for all the patients we are going to face in the future. So those three questions will be: what physiology are we trying to restore? What does VA ECMO resolve and what it doesn't? Will anything change with additional venous cannula? By the end of the discussion, if we are able to answer these three questions, I think my job will be done. So let me start with this multiple choice question of what physiology are we trying to restore? Is it blood pressure? Is it cardiac output? Is it lactatemia? Or is it oxygen delivery? Any answers? If you answered oxygen delivery, you're right. So, the modern current understanding of cardiogenic shock is defined by Sky, who came up with this Sky classification. Obviously, I know that this classification is based on ischemic heart disease. We are concentrating on class D and class E, where our patients fit, who are actually deteriorating despite being on maximum medical therapy. So, before choosing any support, let's understand the basics. So, any cardiogenic shock patient has the fundamental issues with these things: preload, afterload, contractility, and heart rate. Obviously, contractility is the one which is actually causing all the other issues and going into a vicious cycle of non-returning. Now, let's come back to the patient. This patient, if we see the macrocirculation, the patient is already on noradrenaline 0.5 mics per kg per minute and dobutamine 5 mics per kg per minute with a cardiac output of 1.37 liters per minute. And if you see the microcirculation, she presented to us with a lactate of 5. In a couple of hours, it shot up to 11, the central venous saturation of 47, and an AV CO2 gap of 18. So, what should we do now? Should we continue with the escalating of noradrenaline dobutamine, or should we go and choose a mechanical circulatory support? So obviously, once we are at this level of inotropic support, we'll generally go ahead and do this. We think of mechanical circulatory support, which is VA ECMO. Now let's see what VA ECMO does. See, the yellow line, as in the yellow cannula, which is draining blood from the right atrium, is giving blood to the ECMO machine, where the pump actually pumps it to the oxygenator, and then the oxygenator gives the oxygenated blood, which is again returned back to the patient into the arterial system. Now, with the draining, we are unloading the venous circulation. With the pump, we are replacing the failing ventricle, and with the oxygenator, we are restoring the gas exchange. And with the return of the blood, we are maintaining some map. So, in our physiology slide, we are taking care of the preload, we are taking care of the map, and we are taking care of the perfusion of the other organs. Now, if VA ECMO is doing all these things, why do patients still deteriorate? Isn't VA ECMO enough? Let's see. See, of all the good things VA ECMO is doing, there's one thing which is going against the physiology which goes in the body. So when we return the blood in a retrograde fashion into the descending aorta through the femoral artery, all the other basic physiology things like preload contractility and heart rate are taken care of, but the afterload we are actually worsening it by by giving the flow in the opposite direction of the aortic flow. Now, if we say this closely, this increase in afterload is causing a left ventricular distension and increase in the wall stress and increase in the left ventricular and diastolic pressure, thereby worsening the pulmonary edema. Pulmonary edema is already there, and it is worsening the pulmonary edema. If the patient is in ARDS, or in viral ARDS or any kind of ARDS with a stress cardiomyopathy, the lung is going to get flooded with water, and there will not be any gas exchange which happens. The other thing is, so the distending LV can be vented with either an IABP or an impella or a septostomy. Now, the other thing which is going to happen is, because the lungs are already flooded, once the LV starts contracting, it receives deoxygenated blood from the flooded lung, and it starts supplying the major trunks of the major trunks which arise from the arch of aorta. So by doing this, it is actually giving it is actually oxygenating the major organs like the brain and the heart itself with deoxygenated blood which is coming from the flooded lungs. How can we fix this? Probably we can we can bypass the lungs and oxygenate the blood which is coming to the LV, right? The fix for that will be VAV ECMO. Now let's see what VAV ECMO does. Let's go back to the cases and see how bad the lungs were on presentation. If you see, both the patients had whiteout lungs. I would say the second patient had more severe flooded lungs, but both had the severe hypoxia of PF ratio of less than 100. Now we have two patients with similar physiology. Two systems are failing. They both have cardiogenic shock and respiratory failure. They both qualify for VA ECMO, but VA ECMO restores circulation, but we have doubtful coronary and cerebral oxygenation. And if we are looking ahead, both patients might have stress cardiomyopathy with an ARDS, or viral myocarditis where it is relatively reversible in a short duration of time. So if we expect any myocardial recovery, there might be a persistent lung failure which requires VV ECMO, right? In this case, we can go and cannulate them for VAV ECMO, which is a hybrid cannulation. What happens in VAV ECMO is, like we have just seen, we we drain the venous blood from the right atrium. The blood goes through the pump and oxygenator, and while going back to the body, we return the oxygenated blood both into the femoral artery and into the IJV. Thereby, we are maintaining the map, we are draining the RV and reducing the preload. We are replacing that contractility issues, and we are also oxygenating the blood which is bypassing the lung and coming to the left ventricle, and thereby oxygenating the cerebrum and the myocardium. Now, because there are two flows which are going into the body, one is the arterial and one is the venous, we have to split the flow with a Hoffman clamp, and we have to titrate the flow based on certain parameters. The arterial flow is titrated by MAP based on the and vasopressor requirement, and we see the organ perfusion with urine output sensorium, and we see the cardiac output with LVOT VTI cardiac output calculation along with lactate clearance. And the venous flow we titrate based on the pulmonary circulation with PaO2, cerebral oxygenation with NARS, and coronary oxygenation and Harlequin syndrome by monitoring the right radial SpO2, because the right radial artery originates from the brachiocephalic trunk which comes from the aorta. Now, how did our patients do? Let's see. So this patient A, we cannulated her in a remote place, which is 5 to 6 hours road journey from our hospital. And we cannulated her VAV because we didn't know any diagnosis. We were anticipating that she might have a prolonged respiratory failure. So we cannulated her with this hybrid cannulation. We went ahead with the VAV cannulation. and then we shifted her to our facility, where in a week's time her LV improved like this, and LVOT VTI improved to almost 12, and the X-ray also improved. Her saturations built up well, and after a couple of days we discharged her recently, probably on Saturday or so we discharged her. And the patient B, we went ahead with VAV ECMO again, but she required IABP also for LV venting. In this case, she also recovered well, with her LV recovering in probably 5 or 6 days, and the VTI showing around 18, and the cardiac output was 4.23. Her X-ray also did well. She got just shifted from the ICU to the ward. We're planning to discharge her in a couple of days. So in both the patients, in patient A, it was synchronous recovery, where the heart and the lung recovered at a time, and then we decannulated both the artery and vein on the same day. And in patient B, it was little sequential, where we decannulated the artery first, and then a day later we reassessed her again, and then tried tapered off the sweep gas, and then decannulated the venous the next day, and the IABP was removed along with the venous decannulation. So what these two patients taught us was, we never knew the diagnosis when we actually decided to put them on VAV ECMO. The diagnosis came later. Both of those patients actually had viral pneumonia with ARDS and viral myocarditis. But on the presentation day, we know what the physiology was, and we anticipated what they might be heading to, and then the ECMO cannulation was decided based on the physiology of their presentation, and hence after a week they both recovered. Now, is there any literature that says that cannulating these hybrid cannulations actually help? The last 10 years, if I go back to probably 12 years, in 2014 there was a publication where they studied 21 patients, among which 8 patients survived with hybrid cannulations, and all those patients had this combined respiratory and cardiac issues. There's another study which was published in 2015. But they was slightly different in their hybrid approach. They put a VVA ECMO, and they did this in 10 patients, where they hybrid cannulated all these 10 patients with combined respiratory and hemodynamic failure. And there are case reports also which show the similar outcomes. And also recommendations also states that VIV ECMO can be used as a salvage for severe combined and cardiac respiratory failures. Now, the take home messages would be, so we have to cannulate for the expected physiology, not for the current physiology. So in these cases, we could have actually gone ahead and put a VA ECMO, and then waited for the respiratory recovery. And if it doesn't happen, we could have gone ahead and put another venous cannula. But that would have been a patient is already on heparin. Patient is on a high flow of VA ECMO, where the BP and the perfusion is dependent on that. And if we want to go ahead and put another venous cannula, it will be a very cumbersome thing, where there could be bleeding episodes, or there could be peri-arrest situations where we'll have to reduce the flows, right? So if we expect the physiology and cannulate, it will be a better approach. VAV ECMO may be considered when cardiogenic shock coexists with severe respiratory failure, or when early myocardial recovery is anticipated, like as we have seen in the second patient. Once the myocardial recovery happened, we decannulated the arterial, and then we put her on a day of VV ECMO. In earlier cases, we also did this for other patients who required VV ECMO for a longer duration. So cannulating for VAV ECMO on the first go probably is an option. Configuration, flow split, and decannulation should all evolve with the patient's physiology. Obviously, as we have discussed in the slide where the flow split is seen, uh, based on the patient's physiology and recovery, we titrate the flows. Classed VAV ECMO can be planned as a physiological strategy in the right patient rather than being a rescue modification of VA ECMO. So, with this, I wind up my talk. Thank you for the attention. And if you want to contact me, you can contact with these details.
Dr. Nishant, I actually have a second commitment right after, so I wanted to see if I could spend some time to go over the case. Can you hear me okay?
Yeah, I can hear you.
So
Okay.
thank you, Nishant, for the presentation. Ma'am, I think both you and sir has probably seen the cases. The first case was a peripheral, call where we had to go there and initiate a VA. And in anticipation that this patient might worsen, we have put a additional venous cannula. But the second case, probably I think we didn't display the CT here. That was a case of influenza ARDS where that patient also had a very bad ARDS and CT was quite bad. And we know that this patient is going to have a problem with the oxygenation, and we did a hybrid ECMO. So the burning question, the thought process behind this session was, should we consider VA ECMO as the only approach, or should we consider VAV as the prophylactic method where we when we come across such situations, should we consider this as a better approach than a conventional VA ECMO? So that is a question which made us think.
No, it's brilliant, right? Because one of the reasons that in patients with ARDS, we are hesitant to do veno-arterial ECMO, especially if the EF is preserved, is they are ejecting deoxygenated blood. So you're going to have differential hypoxemia, north-south syndrome, and then you're going backwards and saying, let me put them on esmolol or all of these things to close the aortic valve, just so that you can prevent this hypoxemia. So VAV is a great solution because you know for a fact that their EF may be preserved, but they're on massive number of vasoconstrictors, and you're not okay just doing VV. So what we have done in that setting is the same thing, but we have traditionally believed that let's start with VV, see if the hypoxemia improvement will help with the derangements that we are seeing on the vasopressor side, right? We always leave a sheath in, a 5 French, and if it's not working out, it's so easy to just put in the small cannula, the arterial cannula, and put the Hoffman clamp. So no question that there is no right or wrong answer. The only wrong answer is not saving this patient, right? So we have a patient in our unit right now that came in full-blown ARDS, just like your case. And we went in, put the VV ECMO, brought the patient over. Patient was now needing epi, and the EF had gone down. Now, the minute EF goes down on an ARDS patient, you know that VAV is a great choice. Okay, but if the EF is preserved, it's more of a pain to do VV ECMO on them, right? It's a VA ECMO on them because they're going to have hypoxemia. So we changed the patient from VV and we added an additional cannula, made it V-AV. So drain from our cannulas, we put all the way up, we hub it so that we get bicaval drainage, both the SVC and IVC. We've noticed that when we do that, the amount of chattering because of coughing goes down. Then we changed that to V-AV. Then the patient's EF improved. Then we removed the A and made it just VV. And her hantavirus came back positive a month later. So Synnombre virus, there are two hantaviruses, Synnombre and the Andes virus. Andes is contagious. Synnombre is not. Synnombre in the United States, We do have it indigent in New Mexico and in the Texas Gulf Coast. I've been in this field for 15 years. By the way, I'm not a department chief. I am the heart failure critical care lead and the cardiac critical care lead for our 4 ICUs. I don't want to mispresent myself. But in my 15 years, we've not seen HANTA. So I'm like, why did the EF drop? But HANTA cardiopulmonary syndrome, it does. We removed the A, patient is now just on VV. That's a beautiful case for ARDS that is supported on VAV, your cases and my case too. Because you know for a fact that once the sepsis, the cytokine storm goes away, you don't need VA. I do want to warn you all, maybe it's not in India, but it's definitely here, and I'm sure Pramod will agree with me. There is a certain lung bias. Patients that are on VV ECMO, if they need pressors, and we tell the team, I'm going to now go on VA, before COVID, it used to be like, no. What is the exit strategy? What's going to happen to the heart? Are you going to give a heart transplant? Like a million questions. But during COVID, we're like, well, guess what? You have a 34-year-old, the patient has RV shock, you have to go on VAV. There's no option. If you don't do it, we will do it. Like, it was this combination, like we have to do it. But our surgeons and cardiologists, truly supportive, brilliant. They were like, let's go. If you guys believe that this patient will get better, let's go from VV to VAV to VV. And we have shown that that works consistently. The second teaching point is when you have patients on V-AV ECMO, traditional teaching is the lung needs to be rest. You can do FiO2 on the vent at 40% and it's okay. That is not the case when you go on V-AV ECMO in ARDS. The blood that is being ejected from the left ventricle is already poorly oxygenated. If you don't put the vent at a high FiO2, you risk cardiac ischemia because you are putting in deoxygenated blood into the coronaries. So the management of VAV ECMO, number one is Hoffman clamp. Number two, you have to keep an eye on clots because it's VA essentially. Number three, when you decrease the flow on the VAV, you're doing the Hoffman clamp on the V. So you may have reduced flow to the point that you can get clots. So you need to keep an eye. How much flow is going into my lungs? You don't want too much because the lungs will flood and you're making the situation worse. But you also don't want the flow to drop to the point you can get clots. There's no published literature on this. It rarely happens. I've done CTPEs on these patients. They're fine. They're fine because there's a doctor that's thinking, that is looking for it. They're not fine because ignorance is bliss. So you going into ECMO field, you're committed to this patient. You have that ultrasound machine in your hand and you're cross-checking. Where are the cannulas? How is my flow? What are the side effects, the adverse events? Number two learning point, the minute the blood pressure comes up, the A needs to go off. It's not, we will see today, we will see tomorrow, we will remove the A day after tomorrow. Veno arterial ECMO is a bridge. The longer the bridge, the farther the more adverse events. The minute the patient shows signs of LV recovery, the A needs to come out. As mentioned by your team, it is really important to understand VA ECMO hurts the heart. It is not a heart assist device. It's just a supported device because when you put blood in the aorta, the heart is going to require more strength to pump against it, not less. So back in the day, we were doing ECMO, I think 2008 was the initial H1N1 pandemic here in Houston. And in 2008, we used to be like, ECMO drops the EF. We actually have explanted hearts where maybe the beta receptor density goes down. We've never said ECMO harms the heart. We just said this is ECMO lung. When you put patients on VA ECMO, there is this cytokine storm, the lungs become white, and it's not just pulmonary edema, it's something else. Nope, it's all pulmonary edema. This is what happens when you flow 4 liters of blood into the heart
Yeah.
and then it goes back into the lungs. So we've learned over the years to be humble. What we are saying right now is not a dictum, it's experience based care. Be ready to change your thinking with new evidence. Um, I think VAV strategy is here to stay for a long time. But I do want you all to consider if a patient has VA ECMO on and there is differential hypoxemia and the LV is banging, the EF is really hyperdynamic, you know for a fact that the patient should be on VV, but the patient is vasoplegic. Don't be afraid to try novel strategies. One thing that we had done, it didn't work for us, maybe it will for you, is we're like, instead of putting in a venous cannula to convert to V-AV, what if we just put in a swan, like a cordis, like a biggest cordis you can find, and drip oxygenated blood through that? Because the lung has low resistance, right? It will still flow enough. When we did that, we noticed that the tubing tended to get clots in it, but it works. That amount of blood is enough to go hypoxemia, get better. About 15 years ago, when I used to be woken up with the hypoxemia on VA ECMO, because we didn't know any better and we did not have impellers and all of this, we used to start esmolol if the patient's blood pressure was okay. We're like, start esmolol, we'll deal with this in the morning. Basically, we were closing the aortic valve so that the blood, the mixing cloud will go across the arch. So we did all kinds of cowboy, cowgirl things over the last 15 years. But what we now understand to be the truth is every patient needs to be supported. Just because it's two devices, it doesn't make it better. V-AV is an absolute great choice. We used to believe that we don't want to have drainage cannulas in the groins. We can't walk these patients. That's no longer the truth. We walk all patients with FEM venous cannulas. In the Hanta pulmonary syndrome case, the surgeons put in a graft and put in the A as a modified upper extremity approach. So it was just the drainage cannula in the groin so that to enable her to walk. But unfortunately, the ARDS is so deadly that we are just now on VV ECMO and she's barely able to sit up. So I congratulate you in both your cases. Don't be afraid to try these novel approaches. The other approach you could consider is V-AV, but the other V that you're giving oxygenated blood, you could put it in the PA. So the amount of recirculation goes down, right? So if I have a SVC drainage, IVC drainage, V-A through the femoral or upper extremity, and the second V put in a small cannula into the A and give it directly to the lungs. That way, it's like an RVAD, right? It's a RAPA bypass with an oxygenator as well. So when you remove the A, it becomes VV RVAD oxy. So many ways to slice and dice. I think the field is robust. It's a pleasure. I'm a proud Hanmakonda kid. I was there until 10th grade. So it is truly an honor to be here. So I apologize, Pramod. I'm tagging you for the rest of the questions.
Bindu, I'm not as eloquent as you, but I'll try my best.
You're amazing. You're amazing. You're brilliant. Thank you, guys.
Thank you. Thank you, ma'am. Thank you.
Thank you.
So,
yeah, Ravi, I
yes,
think, and first of all, Nishant, thank you for the invitations, and more importantly, thanks to both of you and your team for doing a wonderful job to save the life. I think, these are extraordinary cases, needs extraordinary effort. More importantly, the teamwork which is needs to be really exemplified and also share with the folks so that we all can at least learn from each other. As Bindu nicely pointed out, so there are many ways to help as well as execute the goal, which is how we optimize the physiology. I think there are many folks on the line, so I don't want you guys to really think that we are the expert and we know everything. So I will never say that I'm expert. Rather, I'm also learning from you guys and all the time, because this is a nascent field with so many small tweaks across the world, and each one of them have a different way of achieving the goal. But important point what I wanted to really pass to the everyone from this lecture today and this time is what Nishant, the first questions, the Amitabh Bachchan's question, that what's your goal? The goal here is simple. You are doing, or we are all trying to achieve a single goal. Can we deliver oxygenated blood to the vital organs when they are not working properly? Then the next question comes that are we achieving the goal in a safe as well as smooth manner? And are we respecting the natural physiology with the best way possible? These are the two questions we need to ask. Why I'm bringing all these questions is that just remember there is not a cookbook for initiating or VAV at this moment, because all the literature across the world and then practice is individual or expert opinion. Again, that should not be the case for any of the evidence-based practice in 2026. But here we are talking about this that we don't have, but we are trying. Then you are opening the Pandora box to be answerable to ourselves, our bosses, as well as the so-called the family, more importantly the patients. If they question why the hell you did these things without knowing what you are doing, so we need to answer that questions and be ready for that. That's what the cross point is. So I think there is a question like Pabhaijan, excellent strategy, Ramakrishna. So I think, the question, I agree. But what I wanted to share my perspective is that could you get like, or how do we really decide? So simplest thing, simple. VV is EG. You know that the patient is ARDS, you will do the VV. VA, you have cardiogenic shock. Yes, you will do the cardiogenic shock. VA is simple. And that's why the question arises who and how you decide to go to VAB. That's important. Question number one. Number two, what time you need to think about it? From the time zero, after 2 days, after 3 days, do you have any physiological or patient characteristics to decide that I need to commit VAB from time zero? And then more importantly, what are the precautions we need to take for the folks, those who are in VAV, so that we are not harming rather than helping? And the last question is, when do I come out from VAV to other? That's what we all wanted to know, particularly in the VAB. I don't know what you guys do, but I'm happy to hear from everyone's experience and then approach what they do. But I would suggest, like my approach is, again, I said my approach because again it's the group things, but the simplistic way is VAV. So we need to take into some considerations. The considerations are anything going beyond from VV to VA to VAV or VAV plus anything, that is increased risk. Be honest. Be honest with yourself, be honest with your team, be honest with your family. Tell them that when we are going to this multiple cannulation strategy, the risk of the patients is very, very high from the get-go. So set the expectation for yourself as well as the family, for the team from the get-go. That's number one priority. Number two priority is that also prepare for the complications related to the VAB strategy from the get-go, because the physiology completely changes the moment you consider or adopt VAB. So be ready for that. Number three is that the weaning from VAV to the traditional VV or VA require little bit of more knowledge as well as time as compared to the other things. That's important. I hope I'm making sense. But This is what I think the problem with respect to the VAV in general. I'll stop there and take any questions, like, and at least all of you have. Then otherwise, I'll share how we as a team approach and how we as a ECMO enthusiastic across the world should approach.
Sir, to take this discussion forward, sir. So the first question would be, when should we consider VAV over VA? That is the first question which we have to answer, sir.
Any thought? Anybody? Like, what you guys do in your day-to-day practice, and when did you think about this? You can share or speak. We'll be happy. I think we have 10, 15 minutes.
And I think only the panelists are allowed to talk, sir. So they
Okay.
can only post their questions. So one of
Okay.
the question which was posted was, the patients are usually hypoxic because of pulmonary edema. Should we go for VVA in every case?
So again, this is an excellent question. So it all goes back to, in my personal opinion, again, I am saying this, I'm not an expert. I have been also in the wrong side of the equation because of my opinion. So that's what I wanted to be very honest with that. So does everyone with ARDS and or pulmonary edema cardiogenic shocks needs to go onto the VAB? The answer is no, we do not. The reason being, it's always that the primary pathology which drives the patients to cardiogenic shock will dictate which form of the ECMO we need to consider at the get-go, and is also dictated by the timing. If the patient has a torrential aortic regurgitation, mitral regurgitations, or suppose, let's say, acute coronary syndrome, and they went into the time 0 to pulmonary edema, which is the complication because the heart is not doing you backup, and then you in cardiogenic shock, this group of people may not be requiring the VAB from the get-go, because the moment we support the circulations with VA, and then you have the obligation to take care of the volume from the lungs by diuresis, or maybe once the heart get rest or the respiratory get rest, the oxygenation improve, they will be doing okay. You don't have to do that from that. So that's what the rationale behind that, why we don't need to do everyone. In the opposite spectrum of the equations, like the patients you all share with that, that lady with viral myocarditis or the postpartum things, that look at the CT scan or the chest X-ray. The heart is this big, the pulmonary edema is well settled, you guys are driving 2 hours to go to that place and cannulate, then we'll put back to here. So that time of intervention will be completely different. In that case, you should be safe than sorry. What does that mean? By the time you have the appropriate PEEP to manage the ventilator in the appropriate way to get an optimal flow to the VA ECMO and then rest the lungs is almost impossible. In that case, I would not wait. I would be much more aggressive from the get-go that, listen, I am expecting that this lungs is going to be toasted for next couple of hours. There will be edema, that I cannot diurese him properly. There will be time to like the reactions to the ECMO circuit. Then I have to travel. Then why to wait? Just do it in the beginning so that you avoid many things. You don't have to stop the things, increase the inotropes and recannulate, bleeding risk. So that's what it is. The simplistic way I would suggest all of you probably, or maybe share with you, if you have profound pulmonary edema which seems to be longer durations, I personally think that more than 6 hours or something like that, you have already established pneumonia from the get-go, or you are thinking an infectious etiology as the cause of your viral myocarditis or cardiogenic shock to begin with, and more importantly, when you do the echocardiogram or think that the aortic valve is not opening, that's the tricky part. If your aortic valve is not opening, or you have mitral regurgitations to the starting with, and you have biventricular dysfunction, which is bad, both the RV as well as LV is really bad, So commit from the get-go. That's my opinion. That's one step. The other step I would suggest that if you commit VA ECMO from the get-go, for like when do we switch to VAB? It's a very practical approach. You can commit the VA even if they are pulmonary edema. You know, you optimize the ventilator, but after a couple of hours, 6 to 12 hours, or maybe 24 hours, you see that there is profound differential hypoxemia. Number one. Number two, the edema is not improving, rather getting worse. That you are tweaking the PEEP to 10, 12. You are keeping the 100% on the ventilator for the management, and the lactate is not clearing. You are in trouble, or we are all in trouble. Think about, yes, this is not going to be a practical VA, so I need to go to VAV. So there is an algorithm some people follow. If you put them on VA, then your ventilator should be 10, 10, 10 or 60%, and then PF ratio is less than 200, then we should be considering. Again, that's a rough way of doing the things, but that's also possible. I hope that makes sense. That's the questions, Ravi, I wanted to give. Like, how do you understand to go to that?
Yeah, I think we have answered two questions, sir. One is when to consider VAV ECMO, and then when to switch from VA to VAV. I think these two basic questions we have answered, sir. So the third question which I would like to put across, sir, is you have initiated a VA ECMO and you have a problem with LV getting over distended, and obviously that will eventually lead to pulmonary edema. So the question comes, between putting a venting strategy either in the form of an IABP, which is very commonly practiced here, or use of an impella. Again, the impella goes with impella CP, which is right now available. We don't have high flow impellas at this point of time, versus switching them to VAV. So that is another discussion which comes into the picture when we have such a scenario, sir.
Yeah, I think that's an excellent question. Somebody has also, can ICFELA outweighs the VAB strategy? I think others ask, like others, I'll be very honest with you. If you come and practice with me at Mayo Clinic, the answer is yes. ICFELA does outweighs the VAB strategy, because what we do here is called the Impella 5.5. But if you ask me, and if Ravi is telling the right things, that you guys have only Impella CP, then I'll be hesitant. the the reason being simple. Yes, Impella CP can does the job for you guys for a couple of days, but it is not a good one. Why? One, the risk of hemolysis is very, very high. Then once you commit to Impella CP, then you have already cannulations, then these people will not move around, so you are stuck. And then there is the atriotomy issue, so that's well. The other one is, which I feel is most of the times, that remember that if you are going from the get go, okay, that means you don't have pulmonary edema or minimal pulmonary edema, it's a pure cardiogenic shock, but the LV is really bad, and then you have little bit of like so-called back pressures, and then going to pulmonary edema, that can be taken care of by the impella from the most of the times. However, if you have already severe ARDS kind of picture, whether it's a cardiogenic pulmonary edema, long standing, or you are failing with the diuretics and the patient is going for renal failure or multi-organ failure, I would be hesitant to go for ICPELA as a strategy from the for this kind of things. Why Impella 5.5 works? Because of the flow difference. It's like astoundingly good. It's very simple, like not very simple. You have to go with the axillary cannula. You can go 5.5, and it's do wonderful job. So that is why I would think that. So the question which always we face at that time, even if you go for the LV decompression, still, or are you still going to face the problem of considering VAV? The answer is yes. We do have. If Who are the people? If you have a severe myocarditis with EF of 10%, or you have a myocardial infarction, multi left main gone, the entire, left like the left is gone, and then the heart has a bigger area of necrosis, that heart is going to be stunned for a longer time, and then the back pressure is very, very high. So that group of people, we have personally seen that. And particularly if they have diabetes, or like some kind of ICTD, or we saw this group of people, they are very challenging even with ICFELA. Then what we do, we go for VAV as well as the decompression, and then wait for a couple of days the lungs to be rested and recover. Then you take the V out, and then go for just the ICPELA as a strategy to moving forward. I hope that answered the question.
Absolutely, sir. So the another debating point is that when we initiate a VA ECMO, then we have this problem with the harlequin. So how do we approach this harlequin? How do we address this harlequin instead of before going for a VAV? Or should we consider putting an auxiliary cannulation instead of going for a VAV?
Yeah, again, I think, before I answer this question, I would like to also, I don't know how much you all are being excited or being fearing the challenge that with so-called the Ritter syndrome or the north-south, east-west syndrome. Somehow our folks has been a little bit more excited here regarding the east-west syndrome recently, and then I'm fascinated by these things. Uh, the question what you are asking, that if you have established north-south syndrome, or you are expecting the north-south syndrome, and then how do you manage? So I think I would suggest you, all of you, follow the stepwise manner. So the basic physiological principle in which north-south syndrome works or happens in a VA supported patients, particularly peripheral VA ECMO, is because you are not opening initially, then you open up. Then what is happening is that the deoxygenated blood is coming to the aortic root. That means your lungs are not doing the job. So that is the normal thing. Just understand the physiology. If all of you understand that, if somebody's cardiac output is 5 liter, we cannot take the cardiac output all the time. There is always some flow through the natural path from the pulmonary to the left atrium, then left ventricle, and moving forward. Can we fix that? Sometimes yes. So the simplistic approach, I would say that there is no right cookbook. Yes, axillary artery cannulation can help, but if your lungs are not doing the job, they are atelectasis, and then you have already on the PEEP of 10, 12, as well as a FiO2 of, let's say, 80%, even the axillary artery is not going to really help. The reason being, one, it's not just the flow to the brain. The coronary or aortic root is supplied, and will be, the coronaries will be getting the blood in diastole, and that time everything coming from the left ventricle to the aortic root is desaturated. So the axillary artery cannulation, even if it will compete at the aortic root, so it will be 100% and then something, because if the aortic valve is opening, there will be always something. So it is not going to help. So be careful about that approach. The other one, if the traditional way, I think if you have a north-south syndrome, established north-south syndrome, best way is to put a cannula, to be honest, and then get rid of the equation. And then once the recovery is better, then you will be much more comfortable. Somebody asked here that how to regulate the flow. So remember that, when we are putting or bypassing the flow through the VA ECMO, it's almost like 4 liter there and 3 liter. How much the lungs will really need? It's not much. So in my personal opinion, anything from 0.5 to 1.5 should be appropriate to give you adequate oxygenation to the root and avoid the north-south syndrome. You don't have to really give more.
So coming to the next question, sir. So the next question would be, probably, we are talking about a hybrid ECMO here. So I will go into the intricacies of the hybrid ECMO. So what are the additional monitoring which you need to consider when you're doing VAV? And what are the unique complications which you can expect this with this, VAV compared to a VA ECMO? Sir?
Yeah, these are very excellent two questions. So the unique things which once you start the VAB, and we all have to remember that your chances of hemolysis will be increased, period. Number one, your transfusion requirement, or because of that, and increase the LDH or whatever you guys monitor. So that, make it simple, the chances of hemolysis is going to be increased if you have VAV. Number two, the anticoagulation requirement will increase for sure, because you need to keep the patent. The flow on the one limb, which is mostly the VA limb, is less as compared to the things. And then when it goes to that, so even if it goes to the high pressure, from the, we are splitting from the return line, it's going. But sometimes because of the cannula, the what's the Hopman cannula to regulate that things, it does get little bit of clot at the cannula sites and will be problematic. So that means you are risking the unique phenomena that even during the VAB you will find out that some people do develop pulmonary embolism, which Bindu was talking about. Like at some moment the clot will go, so you'll find out that's one. So hemolysis as well as the increased anticoagulation requirement. And the third thing will be the most important, that your duration of ECMO will be longer. You are not going to just think that it's plain and simple, because the time to balance and then take the VAV component out of the equation will take little bit of more physiological challenge. The next important bedside things is you have to understand that how much is the blood gas and which one is getting what. That means even if you correct the differential hypoxemia in this case, so be prepared to two equations. Are you going to extubate the patients, or are you going to keep the patients intubated? If you are not extubating, your life is easy. If you are extubating, then the life will be much more complex, because you need to really figure it out, what are the places I'm getting the blood gas. So that's the challenge you have. So that is not a cookbook, to be honest. I read a paper from China, or I don't know, they have a complex algorithm, and then that's very difficult to follow. But in my simplistic way, that if your lactate is clear, your blood gas looks fine, and then the patient is minimal support with the inotropic support as well as your vent setting at rest, you are comfortable. Then try to take the one cannula or the decompression sooner than later.
Then, compared to a traditional VA ECMO, sir, so the weaning from a hybrid ECMO, VA V2, either a VA or a VV, what will, make us decide that, probably we are, coming out on arterial first or a venous first?
Yeah. So that's always the challenge. I think, it depends upon the primary pathology. Let's say, for example, if you are gone from ARDS to right ventricular failure and then cardiogenic shock, so that's a separate setting, because in that case, what is primary is that you went from BV to VA, or maybe you go from VA to VAB. So in this kind of scenario, the first thing you need to really take the A out and then consider the V as the primary support. Because remember that the primary pathology here is driven by the lungs, not the cardiac stop. So you support it in the initial part, be comfortable, and take the A out. But in general, theoretically, I always suggest, and I always have the mind, wherever and wherever it is possible, always take the atrial component out of our equation sooner than later. Why? If you are still on the atrial support, whether VAV or VA, the next step is either your life is at heaven or you are going for something else. Because there is nothing else you can add after that. So can we do that thing? So that is the concept. You always, I try to take the atrial component as soon as possible, whatever the form is, because that makes your life much more easier. You know, it's simpler said than done, but that's what it is. As I said, if you are starting with VA, then cardiogenic shock. If you are starting with a VA cardiogenic shock for atherosclerotic cardiovascular disease or acute myocardial infarction and pulmonary edema to start with, I believe, you should be very easy to take the V component out quick, then leave it the VA component, wait for a couple of days, and then go to that. The problem will be particularly the group of people that what you guys are seeing, the myocarditis, postpartum cardiac myopathy, or viral cardiac myopathy, or toxication related. That's very judgment call. You need to really balance with whether the liver is doing okay, the kidney is doing okay, and then how. So what I would suggest, and I always try to come the play around, be honest with your team, bring your surgeons to that. Hey, we are going to do these things, do the echo, see the lab, then what's happening, this fails, go to the other side. That's the way I will approach, because it will be very difficult.
Uh, Sir, because I think as you have discussed earlier, also the literature is not very much available for us to talk on hybrid ECMOs. So based on whatever is the available evidence at this point of time, can we consider as a blanket statement that a VAV is superior to VA in recovery of myocardial function based on the existing evidence?
No, I don't think so. Because rather we should refrain from this statement that VAB is the way to go. Because the reason being that you will be fine, and then, like, this is again anecdotal, very single patient's experience with us, and particularly mine, that even if they are florid pulmonary edema with kind of ARDS, you can be get away with the VA and also IABP, as well as the and diuresis or the CRRT. You don't have to really commit that, because the fear is always that, as I said, the moment you have additional cannula, not only the risk of organ dysfunction, because I think I presented somewhere in Euro also that you know the number of cannulations related to the risk of acute renal failure is significantly high. The odds ratio increased 2 times, something like that. So that's why I think it's not a panacea, because one, you have high risk of anticoagulation, high risk of hemolysis. So I don't think that we should be really thinking about it. Should be very specific as well as individualized approach.
Then probably, I think the last question. So, in a patient with a cardiogenic shock, probably VA ECMO with Impella, then add on a venous cannula versus a VAV ECMO supported with an Impella for a LV distension. Which strategy would be better, or in which circumstances each strategy is superior over the others?
Yeah, again, that's an excellent question. I wish, Ravi, I can bring you here to like do a coaching type. So simplistic think way, if you have a LV which is absolutely dilated and then smoky, called the smoky things on ultrasound, and after you put the VA ECMO, your pulsatility is almost zero. It's flat line. Don't wait for anything. Commit Impella, commit IBP, commit for the VAB get go for initial 48 out 72 hours. Then once things get settled, uh, just change it. That's what I would suggest, because if we are not considering that from the get go, believe me, I don't know how many times you will be called to the bedside at the night or the next day morning. You are scratching, why did we discuss, why didn't I discuss before this? So that was my things. Or second scenario, if you are considering a cardiac arrest patients, or somebody is in ECPR mode, you coded for half an hour, the lungs look shit, there's the aspiration, and then you have difficulty. Don't please think about anything else. Commit from the get go, move ahead. Like that's what. Similarly, third patient, you have a VT ablation patients, they gave 5 liter in the VT, or like in the ablation room, just to keep the cardiogenic shock out of the things. They didn't think about, they already intubated, and then they are coding, and then you are putting them on ECMO. Please don't wait for that, because the time frame, they already touched the cardiac myocyte multiple time with the ablations, and then now you are coming with that heart is not going to do the job for next 48 hours. Commit from the get go, you know. So these are the scenario I would be said. But let's say somebody is coming just to you, you know, there he or she had a MI, just when the right corner is gone, then your team are trying to put a stent, somehow the map dropped and the edema happened. And yeah, you know, that's like the FRC is good, man. They have the flow reserve is pretty good. It's just transient 1 or 2 days. I would not do that. You know, why should I that? Similarly, aspiration, witness aspirations or something like that, I would not do that. Or similarly, post cardiotomy patients, you know, they come up with, they give bunch of volume or difficulty in winning from the your bypass. I don't think we should do that. You know, I hope that's just making sense what I'm talking about.
So I think that brings to the end of the session, sir. And I think that was a beautiful discussion what we had. So as a conclusion remarks, as a closing, remark, what would you like to put across, on this topic of VA versus VAV as a single conclusion remarks?
So please do call Rabi and the team whenever you are in challenge. That's my conclusion. So to be honest, because I think what is happening as in general, not only your part, but in here is that the ask for help for the initiation of mechanical devices is still at the very basics level. We are being called very late. So my conclusion is VA, VAV or VV, it doesn't matter. Please do call us.
Thank you, sir. Thank you for this, wonderful insights into the, this, complicated, situation where there is not much of literature and still we could have a good amount of discussions.
Thank
Thank
you,
you,
sir.
Ravi.
Thank you, sir.
Thank you, sir.
Thanks, Nishant.
Thank you, sir.
Thank you, Nishan. We close the session. Thank you.